Hello, good morning, everybody. So today's topic of discussion is prognostication in heart failure patients. So it's to identify how much prognosis patient landing to you in heart failure has. So it's a quite difficult topic to understand. We know that the burden of heart failure is increasing worldwide, especially in our country. A heart failure patients are younger compared to the Western world. So every 1 in 5 of HFrEF patients get re-hospitalized within 1 year, and the 5-year mortality rate, if you see, it's just 3.1. So it's worse than even some of the dreaded cancers. So heart failure is something which we still have a lot of work to do, and a lot of good therapies are yet to be discovered, and they are required. So how is heart failure in India different from the Western world? So as I already told that our patients are younger. The mean age is 10 years younger than the Western population. And the males and the females are kind of almost equally distributed. Male predominant disease in our setup. And if you see the etiology, it is the ischemic heart disease which is responsible for majority of the heart failure burden. If you see the comorbidities, there are a lot of comorbidities like diabetes and hypertension associated with the heart failure patient. And mostly in our patients, they present quite late to us, and they are rarely on the guideline directed medical therapy. If you see the 90-day mortality rate, it's quite shockingly high. It's about 15%. And in India, if you see 1 in 7, they died within 90 days. And in hospital mortality is also about 7%. So if you just see the stages of heart failure, how the heart failure develops, the stage A is considered to be the patients who are at risk of going into heart failure, but they don't have any structural heart disease at present. These are the patients like diabetes, obesity, hypertension, metabolic syndrome. So our goal is to control this, risk, which is a risk factor for future development of heart failure. And next comes the patient who are having some structural heart disease, like a hypertension patient having LVH, some LV remodeling, patients with previous MI. So these are the patients who are having a structural heart disease, but they have not yet landed up into heart failure symptoms. Stage C is the one where there is structural heart disease. Along with it, there is a prior or current symptoms of heart failure. So these are the patients who are having structural heart disease associated with symptoms like shortness of breath, fatigue, reduced exercise tolerance. Now, this is where our role as cardiologist comes, and the drugs which are associated with reducing the symptoms as well as improving the mortality, and these are the therapy goals. And then comes the stage D, that is refractory heart failure, which requires some specialized interventions also, like a CRT or a LVAD or a heart transplantation. So this is a typical course of a heart failure patient. So at stage 1, you diagnose the patient having heart failure and start on the guideline directed medical therapy. He starts showing some response to treatment. However, he remains stable for a few time, and then that comes a stage where there is a clinical instability, and then there is a stage when there is a very poor response to treatment, and finally the end of life care is what is required. And in between, there are sudden cardiac death even, which can occur at any point of time in the clinical history of a patient of heart failure. So if you see prognostication in a heart failure patient, it is multifactorial, to be honest. It is very, very difficult and actually nearly impossible, because there are very high incidence of sudden cardiac death, and there is some disparity in the applications of the guideline or evidence-based treatment, and there is inter-observer variations in the NYHA classification also. NYHA classification is quite subjective in a way, as the patient describes it. And we are studying a heterogeneous study population. So, actually the mortality, it varies with the individual patient, and it is multifactorial, and that is the reason why it is very, very difficult, to prognosticate a patient who is admitted to you with heart failure. So what are the cause of death in heart failure patient? There are two main cause of death. There is the sudden cardiac arrest, and which is another one is the progressive pump failure. A progressive pump failure is a cardiac death with symptomatic or the hemodynamic deterioration. So this progressive pump failure, sudden death, and sudden death during the episodes of clinical worsening, they each account for about 1/3 of the deaths of the patients with heart failure. So 30 to 50% of all the cardiac deaths with patients of heart failure, they occur as sudden cardiac deaths. So I have already discussed the stages of heart failure. Now, according to the stages of heart failure, the prognosis varies. That is 5-year survival of patients of heart failure in stage B, the ones who are having structural heart disease, it's 95%. And once you are in stage C, then the prognosis is between 50 to 75%. And in stage D, the 5-year mortality is as high, 5-year survival is as low as only 20%. So this is another way of determining prognosis according to the New York Heart Association classification of severity of patients of heart failure. This is a class of symptoms that a patient explains to us. The class 2 is the one which is mild symptom, that is comfortable on rest but is having mild symptoms of normal physical activity. Class 3 are the moderate symptoms, where the symptoms they get developed even with less than normal physical activity. However, they are comfortable at rest. Class 4 patients are the ones which are having severe symptoms with minimal physical activity or even at rest. So based on the NYHA classification, the studies have shown that 1-year mortality in patients who is in class 2 is 5 to 10%, class 3 is 10 to 15%, and class 4 is 30 to 40%. So its 1-year mortality is quite high, especially the patient has symptoms that even at rest. However, this is quite subjective and it can vary according to patient. And a person who is in class 4 at present or class 3, he may well be in class 1 after initiation of treatment. So it's quite difficult to exactly classify a patient into which class he falls. So there are some another effects on mortality in a patient of heart failure. With increasing age, obviously the mortality increases. There are some reports of better outcomes in women. The 5-year survival was 38% in women, whereas the same clinical subset was survival was 25% in males. And there are some seasonal variations also, that the mortality is reported to be higher in winter season as compared to other seasons. So again, it's not the heart failure patients, they may have varied reasons to be in heart failure. It can be reduced or preserved ejection fraction. Apart from that, the etiology also depends, the prognosis also depends on the etiology of which the patient has landed up to you in heart failure. Some disease have a very nice, good prognosis, like patient of peripartum cardiomyopathy, they generally recover in 6 to 1 year. And if the patient is having no cause associated with the cardiomyopathy, that is what we call as idiopathic cardiomyopathy, they also have a reasonably okayish prognosis over time. And if you see, the worst prognosis are associated if the patient is having ischemic heart disease associated cardiomyopathy as well as cancer chemotherapy related cardiomyopathy. Now these are the conditions, and infiltrative myocardial disease such as amyloid or hemochromatosis. So these are the conditions where the patient landing up with you in heart failure having these conditions, they perform worse as compared to others. So this is a very important slide to be noted. With hospitalization, with each hospitalization, your mortality event rate increases. So 56% of the patients are re-hospitalized within 30 days of worsening heart failure events, and it keeps on increasing with time. And the median survival goes down, as you clearly see, with the number of hospitalization. With each hospitalization, your median survival rate goes down. So you have to really be, as doctors, really have to act highly on the very first hospitalization which the patient has, because as and when the number of hospitalization increases, the chances of survival goes down drastically. So what are some of the predictors, you can say, of worst outcome? The one which I already told you is heart failure hospitalization. If it's not tolerating the guideline directed medical therapy with raised creatinine, a low blood pressure, a lower ejection fraction rate, hyponatremia, anemia, some dysarrhythmias, along with the multiple comorbidities, these are the subsets which perform worse as compared to the others. Another important aspect which I wanted to highlight is that the important role of kidney in the patient of heart failure. So whenever you have to look at the prognosis, you can look at to kidney, because CKD is associated with doubling of the risk of all-cause mortality in a patient with heart failure. So these are some of the therapies which we have in our armamentarium to stop the disease progression of heart failure. There are some drugs which can be tried, CRTs, that is a cardiac resynchronization therapy, which can be tried. A patient of ischemic heart disease should be revascularized. If he's having problems with the mitral valve surgery can help apart from the medical therapy. And stage D patients, they will require transplantations or LVAD support. So with the present day treatment, we surely have reduced quite a number of the worse outcomes or events which happen with our heart failure patient. We have A's, ARBs, they reduce up to 20%. The beta blockers, they reduce mortality up to 39%, and the mineral corticoid receptor agonist again decreases a further up to 30%. So it's very important for our patient of heart failure to be on guideline directed medical therapy, because these are the drugs which have shown to be of benefit in terms of reducing the mortality. Now there are some prognostication models available which help you to predict your patient of heart failure, how much prognosis or how much life expectancy that patient has. However, these are some of the fews which are mentioned in the slides, some by Fenner et al. Or Levy et al. Effect model, but the one which is frequently used is Seattle heart failure model. It looks something like this. There are various characteristics. There are drugs which are taken into the account, and then there are some lab parameters, and you can see the prognostication, how the prognostication would change with the therapy, how the mean life expectancy of 4 years can be converted to 9 years with therapy can be done with this model. So we can use this model for our patients. However, there are some benefits and some limitations. Benefits is gives some expectation regarding the prognosis, and it's help us unable to improve the quality of life. And we can discuss these things openly with our patients. However, there are a lot of limitations. That is, the patient's compliance to the therapy, his attitude is not incorporated. Newer therapies will become available with time, and these scores they have replaced you can't just tell the score, just put everything in score and say that this is what amount of life you have. There is a informed compassionate conversations are actually required, which is more important to prognosticate our patients rather than these scores. So the use of this course should supplement, but however they cannot replace the clinical judgment. So then comes the role of palliative care in heart failure. Definitely, there's quite a role of palliative care in decreasing the symptom burden. It helps increasing the NYHA classification, improves the quality of life, decreases the heart failure hospitalization rate, and reduces the healthcare cost also. So to summarize, amongst patients with heart failure who are considering therapies such as heart transplant or LVAD or palliative care, a prognostic information can further help you to make an informed decision regarding the risk and benefit of the therapy. Prognosticating models are available which can be used in selected clinical scenarios to more accurately communicate the prognosis to the patients, but however they should not be routinely used to guide the therapy. And at present, accurate prognostication of patients with heart failure remains challenging. That the very fact of which I have already explained, the multifactorial disease of heart failure, and so the prognostication of this patient remains challenging. However, newer therapies are coming up which reduce the mortality, and we hope that further newer therapies come up for the patients of heart failure, because the prognosis of heart failure patients is really bad, and those require some good therapies. Thank you very much.